Now, when COVID came out, we were all scared. People were dying all around the world. Hospitals were full. They were getting refrigerator trucks for the bodies. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is my good friend, Dr. Nathan Beckett. Welcome to the show, Nathan.
Thank you very much for having me.
Nathan is a local pediatrician here in Missouri. He works at Tiger Pediatrics, and I've known Nathan for years. So welcome him to the show, Nathan.
Yeah, my pleasure to be here, and thanks for having me today.
You got it. Nathan, we're going to talk today about childhood vaccination. The COVID pandemic is mostly behind us. People still get sick from it, but there was a lot of controversy about vaccination for COVID, and I hope to end our conversation on that topic. Okay? Now, you're a very interesting guy. You worked in the Peace Corps when you were younger, and you went to Haiti.
Yeah.
So you've seen third world countries, and you've probably seen firsthand the ravages of childhood diseases.
C'est vrai.
C'est vrai.
So, it was a really formative experience in my 20s. And so, the things that you see in Haiti that get addressed early here are things like, clubfoot, some of the vaccine preventable diseases. And so it was enlightening, and I was living in a place in the middle of nowhere in Haiti. And so it was a really great experience to work with a local kind of a hospital system that had some outreach into the provinces, go meet people, where they were.
Yeah.
And so that was the first time I ever kind of took vaccines from one place to an outlying area. And interestingly, that's what I do now too.
Interesting. So it makes you full of gratitude for what we have here.
Absolutely.
Yeah. Now, you're a big guy, Nathan, and apparently you were a defensive end back in high school and Westminster College for a little while.
Yeah. So I played football, and that's a great conversation I like to have with patients and families, because I have a real love-hate relationship with the sport now.
What I was leading up to is here you are, a big guy taking care of little patients. What drew your interest for pediatrics?
Well, I just felt a calling during residency, and I felt like that was one of the things that interested me most. I connected with family members and with parents, and I was already a dad, and so I kind of understood the perspective of being a parent, but also sort of a childlike nature. So I connect with the kids a little bit too. So I enjoyed that aspect of it, and realized that this is the future, and this is something that I can do to maybe touch a few lives and maybe improve some prospects. And so I felt like that was a really good place for me to focus my efforts. And so that's one of the reasons that I chose pediatrics.
Yeah, it's really remarkable as like everyone most people, I will always remember my third grade teacher, these formative people early in my life. So you are touching these lives early on, Nathan, and you get to see them grow up, and you get to see what you've done for them have ramifications all the way down the line, and that's really, really cool. We have heart surgeons on here, and I will tease them. If you do a bypass in a 70-year-old person, what do you get? An extra 10 years, 20 years. You treat a pediatric patient for a problem. You've changed their whole life. Now, I think I trump everybody because I do infertility. I give somebody a child, and who knows how many millions of people go down the line there. But it is very rewarding, and I'm so glad you're a pediatrician here in town. So let's talk about the history of vaccines. Vaccine comes from the Latin word vacca, which means cow. And I believe that came from around the time of Jenner. Jenner figured out that if you take cowpox scrapings and you sniff them or you poke them into the skin, you can immunize or prevent smallpox, because I think he noticed that milkmaids didn't get smallpox. So it comes from vacca, meaning cow, but maybe a better word is immunize. What is immunization, Nathan?
So I think it's meant to provoke an immune response, so a way for your body to recognize something, foreign invader, an antigen, if you will, of some kind, and mount a defense.
So it allows the body to have experience, and the body has memory to these antigens, which are generally things called proteins, or these surface chemicals on the surface of viruses or bacteria. So we can purposely give experience to the immune system so it recognizes it. So if it's exposed again in the future, it's ready to go. We've got memory cells, it fires them up. Bam, you can mount a life-saving immune response. Is that accurate?
Yeah, I think that's pretty good. I mean, I think it's probably the most important thing that we've done in medical science. It's the kind of the medical equivalent of landing on the moon.
Yeah.
So I think it's a really one of the most important things that I can do as a pediatrician is to recommend vaccinations.
Yeah, and these immunizations. Now, I looked up some numbers before this talk, Nathan. Apparently, you can, depending on how you count them up, we can immunize a child against 16 to 20 life-threatening diseases. Apparently, at least 5 million lives a year are saved with vaccination. If you're a number cruncher, apparently if you invest $34 billion into vaccination and immunization, you can save $1.5 trillion in savings and whatnot. So if you just want to look at it from a return on investment point, view, tremendously powerful and tremendously helpful. I am old enough, Nathan, that I remember when I was playing, we would have a rain and the sewers would overflow and we'd have rivers running down the street. I remember my mother being terrified I'd go out and play in the water because that's how they caught polio. And so it's not too long ago that just rainwater could give you polio and paralyze you and change your life. I have a scar on my arm, Nathan, where they put a little thing on there, took a little needle, where I was immunized against smallpox.
Mm-hmm.
And vaccination has become so effective that smallpox has been virtually eradicated off the face of the earth. Polio has almost been completely eradicated. I don't know the numbers. I don't know if there's been a case in the United States for a long time. I think there were some pockets of polio that we've got these public health people that go around the world trying to get ahead of little pockets of polio outbreaks, but that's almost completely eradicated.
Yep.
So there's some tremendous stories here of success that are just earth-shaking, and they have changed the world.
Yeah.
So let's talk about basic childhood vaccines. A child is born. And I won't talk about the mother. We make sure the mother is, by the way, immune to German measles, which can cause horrible birth defects. In a lot of cases, infertility, we make sure the woman is immune to something called cytomegalovirus, which can cause horrible infections when a baby is in utero and cause horrible birth defects in children. But let's say a child is born, healthy mother, gets seen by a pediatrician. Where does vaccination start?
So there are a couple of vaccines that you hit on already, and within the last 6 months, we've actually been doing another one that's kind of added to the mix, which is not exactly the same as the other immunizations because it's a monoclonal antibody shot, and for the mothers, that's called, I think it's Abribcio. I don't know how to pronounce that specifically, but the the infant version is called Beyfortus, and it's a passive RSV immunization.
Respiratory syncytial virus, something that cause horrible pneumonias and infections of the upper respiratory tract.
Yeah, very very dangerous infection for infants younger than 8 months old in general, but very specifically worse for kids with congenital heart disease and other respiratory factors.
So that's not a vaccine or an immunization, but it is the active antibodies that an immunized person would make. So they're already right there to latch on to this virus and guide the immune system to it, to help it.
And so we've had a version of this medicine for a long time, and I think almost 20 years. And but now it's more widely available. It's cheaper. It's more effective. And so we've instituted that this past RSV season, which is nearing completion now. And so during the summer, probably won't be giving it, but then next fall, when RSV season is again upon us, we'll be giving it again.
So RSV has a season. It's in the fall and winter. I didn't know that.
Yeah, and so there won't be data on how well it's actually prevented severe outcomes, hospitalizations, for another few months at least. But anecdotally, I think it has been a useful new tool that we have to fight RSV. So that's one kind of a newer thing that we're doing more widely than we used to.
So a child is born. What are your recommendations? You've got an otherwise healthy child, new mother. She's heard all this stuff about vaccines. Maybe she hasn't done much reading about it. What are the first things you recommend? Do you recommend vaccines for a newborn baby?
Yeah. So the first one we do is the hepatitis B #1. The first shot of the 3-shot series is done usually on the day of birth or on the within the first 24 hours of birth.
And that is a protein, I believe, to hepatitis B.
Yeah, that's right.
Now, I'm going to play devil's advocate right off the bat, Nathan. Let's say the mother is, clean living. She doesn't shoot drugs. She's not promiscuous. She doesn't have Hep B. Got a monogamous couple. They're going to say, why do I need to immunize my child against hepatitis B if we don't have it?
Well, because the most cases of hepatitis B come from parents who don't know that they had hepatitis B.
Okay. So it's a silent thing. People are chronically infected. And if you look at this once again, I call them bean counters. These are public policy people that look at these big numbers. If you look at the big numbers, all comers, hepatitis B vaccine, I believe, has virtually eliminated chronic hepatitis B in children in the United States.
Yeah, it's a very bad infection and can cause lifelong problems.
Yes. And as healthcare workers, you and I are vaccinated, and they make sure we're still immune.
Yeah.
It's crucial that you and I not contract it or inadvertently spread it.
Yeah, and it's a safe and effective vaccine.
There's very few side effects. And we're going to get into that a little bit later, too, because that's, I think, the biggest fear is this vaccine going to cause illness? Is there going to be a side effect? So in the hospital, baby might be vaccinated for Hep B with the parents' consent, and that's it at that visit.
Typically in the hospital, yes, yeah, and as soon as the baby is discharged from the hospital at the first newborn visit during RSV season, then we would offer the Beyfortus vaccine.
And that's an injection as well.
Yes.
An intramuscular vaccine. So I just want to go to the typical scenario, the typical flow here. So parents bring this otherwise currently healthy baby for a well baby checkup. They come to you, Nathan. Mm-hmm. First visit, second visit. When do these immunizations start, and what are they?
Yeah, so depending on the practice, there are some mild variations and timing, but they're all hit on a general CDC kind of a guided regimen.
Centers for Disease Control and Prevention. Mm-hmm. So these are national guidelines, best practices that have been evaluated by scientists once again, with large data sets, large population surveys, looking at the risks and the benefits of these things. So 1 or 2 visits later, Nathan, at what age? At 3 months of age, 6 months of age? When would you start these?
So typically,
vaccines?
the course that most practices follow is a kind of a 2, 4, and 6 month regimen where we get a few of the first year vaccines. Some practices do that second hepatitis B shot at like a 1 month checkup.
Called a booster.
Yeah, the first booster of the hepatitis B series. We usually do the booster of the hepatitis B at the 2 month visit along with pneumococcal pneumonia vaccine.
All right, now pneumococcal pneumonia, that's not a virus, but it's a disease that can cause pneumonia as it's described. Now, is that different from Haemophilus influenza?
Yes.
That's another bacteria. Most of the vaccines you are given are against viruses, but so you've mentioned 2. I've mentioned the second one, bacteria that can also be immunized against. So pneumococcus, I didn't know that.
Yeah. So pneumococcus, and generally speaking, there's usually a multi a vaccine with multiple different antigen particles. So we do a vaccine that's got the DTaP shot, which is diphtheria, tetanus, and acellular pertussis, better known as whooping cough. And then it also, in the combination with those 3, also has a bit of the Haemophilus influenza antigen.
So you give a DPT, you said at 2 months or 4 months?
The DTaP.
DTaP, okay.
And it's actually, in our practice, we use a DTaP, polio, and Haemophilus influenza.
So they've got polio in it as well now?
Yeah. Inactive.
Fantastic. So you can then go play in the sewer like I used to.
Yes.
Or at least the sewer water.
Absolutely, yeah.
All right, so you can get, so that's very easy. That's just 1 injection.
Yeah, so there's usually 3 shots and then a drop of the rotavirus vaccine, which causes infectious diarrhea, which can be...
Oh, rotavirus is horrible. You hear about cruise ships and whatnot where everybody gets just the horrible. I believe I had it once. It was miserable. So that is a drop?
Mm-hmm.
You give that under the tongue?
That's right.
And that promotes an immune response, I guess, in the oral cavity where your tonsils are and whatnot. And that...
Yeah, and
gives you
it works.
antibodies.
I think it works. I think it works in the gut.
Okay.
And so that's so those 3 injections and the 1 drop in the mouth. Those are typical, or what we give at the 2 month and the 6 month visits.
Okay.
We skip the hepatitis B at the 4 month visit because you need the 3rd hepatitis B at least 6 months old. So
really, there's even another booster to give probably close to lifelong immunity, hopefully.
Yeah.
Once again, we're revving up the immune system to recognize this invader if it should ever come on board. So now we're up to around 4, 6. So wait, when you have well baby checks, do you see a growing baby about every 2 months? Is that what I'm hearing?
Yeah, there's a pretty usual course for a baby without any other risk factors or problems. So, I mean, we usually do a 2 month, we usually do a 2 day, 2 week, 2 month kind of initiation and practice, and then 2 months, 4 months, 6 months. And then you sort of, from there, start to spread out a little bit. 9 months, 12 months, 15 months, 18 months. So that's 3 month intervals. And then you could step up to 6 month, 2 year, 2.5 year, 3 year. At that point, you're on annual visits. So
obviously, I would love to have you back sometime, Nathan. We talk about childhood development. I find development just fascinating. So have a lot of scientists and whatnot. So you're obviously checking all kinds of things on these visits, making sure they're making what are called milestones and growing within normal limits and whatnot. So in that first year, Nathan, maybe we can summarize. They've been immunized, vaccinated against diphtheria, pertussis, which is whooping cough, tetanus, polio, RSV, hepatitis B. Are there any other diseases that start becoming important later on?
absolutely.
Tell me about some of those vaccinations, Nathan.
Haemophilus influenza, to add to your list, also importantly, is influenza.
And flu, the flu vaccine.
Yeah.
That flu vaccine, it is reformulated every year because influenza is a moving target, isn't it?
Yeah, it is. And so the way that we do it is that the manufacturers take I think the four most common strains that are identified in the previous season.
And this is a worldwide surveillance. They're looking down in Australia because it's winter there right now, or the different season there. And they're getting some idea what might be coming through our flu season, I guess.
Yeah. And so it's updated, and sometimes it's anybody's best guess exactly how effective it will be the following year, but it tends to follow a similar course, and so the last couple of years it's been a very effective vaccine.
Yeah. So success rates go up and down depending on whether they hit or miss the proper antigens there on the viruses. Now, Nathan, I'm allergic to sulfur and thimerosal, these preservatives, and it's a horrible allergy. And these multi-dose vials where you've got a vial and you don't want it to get contaminated, and you've got a lot of doses there, and you want to pull many doses out for cost savings, travel, Haiti, or whatnot. You want a multi-dose vial. But if a parent is concerned about that, are these influenza vaccines now do you frequently give the single dose that doesn't have the preservatives, or do you have that option?
I think the biggest concern that we've had traditionally is egg allergy.
Egg. That's right, because the virus is grown in eggs, isn't it?
And yet, the more recent research is actually still now more recommending that unless you've had a very specific reaction to the flu vaccine before, that it's safe to get it even with an egg allergy.
So because there's got to be trace. It's got to be an awfully low trace. These things are so ultra purified.
Yeah, and certainly parents are invited to have the vaccine and stay for short observation time after it's given in the office. If there's any question at all about that. So,
but put a finer point on this. Do you have single dose options of some of these vaccines without the preservatives in them? Are you aware of that?
I'm not sure.
You're not sure? Yeah. Because I really made a stink. The hospital insists that I be vaccinated every year for influenza, and I've got to document it. I get very sick if there's any thimerosal. And they said, oh, no, we have these single-dose vials. I said, all right, and I did it, and I felt fine. Yeah. And I haven't had the flu in a long time.
So obviously there are options available for those kind of specific concerns.
Now, when do you start vaccinating against measles, mumps, and rubella?
Yeah.
Now, measles is horribly contagious. Apparently, it just takes 4 or 5 or 6 little virus particles to catch measles. It's unbelievably contagious. When do you start vaccinating against measles and whatnot?
Yeah, so measles, mumps, and rubella are usually part of a single injection, and that's at the 1-year mark.
Okay.
The measles, mumps, rubella injection is one that we do at the 12-month visit, as well as varicella, which is commonly known as chickenpox.
Right. So let's talk about varicella, chickenpox. I don't know how many people will die if they're exposed to chickenpox. I remember getting it as a child. I remember being sick. And many of us probably know it as someone with a scar or a pock on their face that it can leave sometimes devastating scars. But I've heard people saying, well, maybe it's better just have a pox party. One kid has chicken pox. I know women will get on the phone, or I guess they get on a Facebook group and say, hey, come over to my house. We'll have a party and we'll pass my kid around and everybody will get exposed to chicken pox. I believe it's purported that gives better immunity. But what do you think about that? Obviously, there's dangers associated with that as well. To talk about that for me, if you would.
No, I mean, like you, I grew up at a time where that was the plan for immunization, and those people that have never been exposed and never been vaccinated, if you get chickenpox later in life, then it can be more devastating and dangerous.
The older you are.
Yeah. Now, we know now that it's a better idea to get vaccinated.
Unpack that for me, please. This is very important.
So one of the dangers of varicella is that it could actually cause encephalitis.
Infection of the brain.
Yeah. So
And in fact, in pregnant women, I've got a little experience with this. Pregnant women whose immune system is somewhat suppressed, they get chicken pox and it goes to their brain. It is a life-threatening problem. Now you've got a very sick woman who's also pregnant, whose brain is now swelling and getting damaged. So the vaccine clearly reduces encephalitis.
mm-hmm. Beyond that, varicella is one of these viruses that just once you have it, it tends to stick around. So it can hang out in your body for forever. Later in life, it can kind of show up at unforeseen and unplanned times.
And that's called shingles.
And it hurts.
Yes.
It hurts really bad.
It sits in these little nerve roots in our body. That's why it comes out in stripes, because it corresponds to a thoracic, what's called a dermatome, a stripe. So that virus is sitting in there. It can sit in your trigeminal nerve, and you can get it on the face. And if that affects the eyes, it's a big deal. But how would you counter the statement, well, if I had natural chicken pox, then maybe my immunity is stronger because of that? Is there any science behind that?
I don't know real specifically the numbers about the chance that you're going to get chicken pox if you've had the vaccine. The likelihood that that previous episode of chicken pox is going to prevent you from having it more than having the vaccine. But I think that your chances of getting chicken pox are just dramatically reduced
if you're vaccinated.
If you've been vaccinated. I think it's a very effective vaccine. So.
Yeah, and then I see these on TV all the time, these vaccines against shingles. It seems to be just like a chicken pox booster.
Yeah.
Essentially.
Yeah.
Keep it suppressed. It's really funny, people will smoke and drink and whatnot, but if you tell them it hurts their skin, their appearance, and all of a sudden, lung cancer might not stop you, but if it says it's going to wrinkle your face, then sometimes people take more heed. So it would certainly reduce the amount of pox and scarring on your face. Maybe we could make it more popular for a cosmetic reason.
Every reason is a valid reason.
They're all good. As I'm fond of saying, Nathan, we're not logical creatures. If we were logical, the world would be a very different place. So at 1 year of age, now a child's getting an MMR. And by the way, we see women, when I have a woman come to me who wants to get pregnant, we test her for immunity against German measles, against rubella. It's very important because it's still around there. It's still out there, isn't it? Yeah. It still circulates. And if you have a woman who's pregnant who's naive, meaning she hasn't been exposed to it, it can cause horrible problems. So you can't get the rubella vaccine by itself. So if I have a woman who's susceptible to rubella, we just send her for an MMR, and she gets a measles and mumps booster on the side, along with that MMR vaccine. And we make sure the woman is immune against rubella. So that was age 1. Now we're 1.5, 2. Do other vaccines come down the pike, Nathan?
Yeah. So the other newer vaccine that we I guess more that's not the right word. The other vaccine that we started within the first second year of life, I should say, is hepatitis A.
That is transmitted once again by dirty water, by what's called fecal contamination of water. And I know if anyone is planning on traveling to, I hate to say third world or countries where it's still endemic, highly recommended that one be immunized against hepatitis A.
Mm-hmm. Yeah, and so the Centers for Disease Control also has a very good website about specific region-specific recommendations for immunization before you go, and for potential problems, whether it's dengue or malaria or hepatitis or typhus.
These are once again gut diseases.
Yeah,
I think typhus is a bacterium. Once again, horrible let's just say bowel issues. Diarrhea is not a sexy topic, but boy, it's one of the number one causes of infant mortality around the world.
Yeah. So those are hepatitis A, varicella, measles, mumps, rubella. Those are the three kind of newer vaccines to the second year of life, and then you get a couple other boosters. You get a booster of the tetanus shot, and you get a booster of the pneumococcus shot.
Tetanus lasts a long time, doesn't it? Mm-hmm. And I believe the incidence of now tetanus occurs when the bacterium, it's Clostridium, grows in your body. Any place that doesn't have much oxygen, it can grow, and it secretes this horrible protein, this powerful toxin, locks up your muscles, and it can kill you, can't it?
Yeah.
So tetanus is very important because kids will be kids, and they're gonna get cuts and pokes and step on sharp objects and whatnot.
Yeah.
It's nice to have that immunity in advance.
Yeah, and Clostridium loves the dirt, and so do kids.
And so there you go.
Yeah.
Yeah. So later on, Nathan, I know I'm testing your recollection here, but any other vaccines come up later on in childhood that you might be recommending?
Yeah. So the measles, mumps, varicella will need a booster. We usually do that booster at 4, and once at 4 years old, and we usually do that all in a single shot combo. The hepatitis A gets a booster as well. So sometime 6 months after the first one. So usually in our practice, we do that at 15 months and 2 years. And then we get another booster for the DTaP polio, which is a single combo shot at the 4-year visit. So a couple boosters at the 4-year visit, one at the 2-year visit. And aside from flu vaccines, those are the general recommendations that we usually have.
And with children, do you recommend flu vaccine every year as well for them?
Absolutely.
Absolutely, because there's measurable benefit. Now, Nathan, here in the Midwest, we have a great variety of patients, lovely people, different backgrounds. And here in Missouri, and I know in Kansas and Indiana and Pennsylvania, we have enclaves of what are called Anabaptists. These are Mennonites and Amish. And from Kansas, I've had patients from Kansas that are old order Amish, where like ultra strict, like ultra orthodox Jewish patients we have that they're so strict that I don't believe they like to do vaccinations.
Mm-hmm.
And I believe you have a clinic north of here and a lot of Mennonite and Amish communities. How do you handle, like I have a patient just recently, an Amish patient came to me, and she is rubella susceptible, and she wants to get pregnant. And here I am. I'm going to have to tell her, gee, ma'am, you are ripe for rubella infection in pregnancy. I know she's not going to take the vaccine. So how do you approach vaccination in populations that traditionally do not get them?
I think that's a tough question. I think every physician will have to come to that answer on their own. In my practice, I do discuss the risks of not being vaccinated, both to
because you have to tell them.
Yeah,
you have to tell them. I mean, it's part of informed consent.
So there's I have to talk about the risks to the child. I have to talk to the risks about people in contact with that child. Because there's certainly non-zero risk that child could get one of these diseases, which can be devastating, or spread it
around.
Yeah.
So I know some pediatric practices in some of the metro areas I've lived in, because I had a kid. We were raising a kid, and if you didn't follow the vaccination schedule, they would fire you. They'd say, "Gee, Mrs. Wilshire," it wasn't her, but I can use my name. Mrs. Wilshire, we're not going to see your child anymore. We don't want your child in the waiting room with chicken pox, spreading it to our other kids. Yeah. Which sounds draconian. I understand the rationale behind it, but do you fire patients if their parents don't get the vaccines? You just counsel them and.
Yeah, at this point, I don't.
You don't fire them, and you will see them.
And and I don't plan to change that. That being said, if if I understand that there's a child who is unvaccinated who has potentially chickenpox, then I would make special accommodations to get them seen without being, in the waiting room for long periods of time.
Yeah, some practices have a separate waiting room,
Yeah.
I believe, for sick children.
So and that puts some stress on my practice.
Yeah.
So it's a difficult decision, but I do want to know that I want families to know that their child deserves health care.
Good for you.
That's the decision I've come to at this point, and I don't plan on changing that. But nobody knows what the future holds, but that's not my plan. So
Yeah, I've mentioned this in other podcasts. There are 4 basic ethical positions one has to use in providing health care, and one of them is autonomy. If the person has their marbles, they're thinking clearly, you should be able to give them the information. You need to respect their decision. That's called autonomy.
Mm-hmm.
Also a concept called justice, which means we need to look at the greater good. So you are balancing justice and autonomy here, and it's not an easy tightrope to walk sometimes.
yeah, and I think there's a lot of different ways to try to thread the needle. But I, that's the decision that I've come to at this point, and so we'll basically adjust our positions as need be. But I'm going to recommend vaccines and until the point where we find evidence that there's some better thing to do. And in that case, I'll change my practice.
Because autonomy works both ways,
Yeah.
Nathan. We have to respect your autonomy too
Yeah.
to make an intelligent decision.
Yeah, but the evidence is that it works very well.
Sure. No, the overwhelming evidence is here, and that's one of the reasons we're having this talk today. I want to convey this very important information to our listeners,
Yeah.
so they can make intelligent decisions and probably go with the majority.
So those are the kind of the early childhood vaccines we talked about, basically 1 through 4 years old. Then there's a little bit of a gap, and it's an interesting time in a child's life, in a pediatric kind of office life, where you just go on annual visits and you do checkups, and you make sure wellness, all the different parts of it, whether it's sleep or development, and you're looking at all of that. But once you got a couple of digits and you're 11 or so, then we do some other new vaccines. So at least in our practice, we usually do 3 shots at the 11-year check. That includes the meningitis vaccine.
Meningitis, yes. You hear about that. A college kid gets a headache, goes to sleep, and doesn't wake up.
Yeah.
These things happen. So what kind of meningitis is that?
So meningococcal meningitis.
Meningococcal. That's a bacterium.
Yeah. And so the meningitis vaccine, actually the typical one that we do right now is got 4 serotypes. It has the A, C, Y, and W, ACYW serotypes.
4 different strains of bacterium in that cluster.
Yeah, and then there's an additional meningitis vaccine called the meningitis B vaccine.
That's the one I see on TV, I think.
Yeah, and so that's a newer one that's not part of the mandated series. So
that's why it's on TV, because they gotta drive some consumer demand.
Newer, it's been around for years, and I think it's a relatively it's a safe vaccine, and in point of fact, actually causes more meningitis cases than the other 4 serotypes combined, because we've done a much better job vaccinating against those.
The other ones are down,
Mm-hmm.
so that one has risen to the top.
Yeah,
in incidence.
So the meningitis vaccine we introduced at about 11 years old, and that gets a booster at 16.
Gotcha. So they're off to college, should be well. They should have lots of memory cells against that potential invader.
And then you get a different tetanus shot when you're 11 as well.
Tell me about that. I didn't know that.
So the early in life you get the DTaP. Once you're a little bit older, you get the Tdap, and that just means that there's a little more tetanus antigen in that vaccine.
And pertussis is now gone from that one.
Pertussis is still in it. So diphtheria, pertussis are still.
I lost control. Let's count the letters.
T later, D earlier. So
Okay.
But pertussis is actually, it's really an important part of the vaccine, especially if you're going to be around a baby, because a whooping cough can be devastating and can be deadly.
Right.
So if you have an infant child at home and an older sibling who's not vaccinated against pertussis, then they need to be updated. So
the older child can bring it home.
Yeah.
All right. What other vaccines? So now we're getting into the mid-teens. What other vaccines come up now?
So the HPV vaccine, Gardasil, it's a very important vaccine.
Yeah, papillomavirus, folks. This causes cervical cancer. It causes a lot of headaches, a lot of problems, and it can affect fertility because the treatment for papillomavirus of the cervix frequently involves some surgeries. And they're called LEAPs. You have to cut out the diseased tissue, the precancerous tissue. Hopefully you catch it when it's precancerous. And believe it or not, that can affect the cervix and a woman's fertility.
Yeah, and it's a leading cause of cervical cancer in women. It's one of the leading causes of throat cancer
and throat cancer as well. Correct. So, I think Michael Douglas talked about that a few years ago.
That's and so it's one of the very few things we can do to really prevent cancer. So I strongly recommend it. Right now, it's not mandated, but I think strong consideration should be for everybody to have it because.
And the number one concern, obviously, is side effects and whatnot. I believe these numbers are constantly being surveilled, and they've got to be very, very rare. I think less than 1 in a million. I could be wrong.
Yeah, and I think all these vaccines have very rare serious side effects, but the majority of them are site specific. The inoculation site, pain, redness, and swelling.
Site specific. So It's affecting where you get injected. It's going to be red. It's going to be sore, perhaps. As far as killing you, it's exceedingly rare.
Exceedingly rare.
Gotcha. Any other vaccines? You're doing such a great job educating me here, reminding me of these. Any other vaccines come to mind before they leave your pediatric track practice and go off to internal medicine?
Not in the general sense, no.
So that's pretty much, we've covered them all now.
Yeah.
Fantastic. Thank you, Nathan. So now we'll get into the controversy. And the reason I mentioned the history of vaccines is it's really important to know how they work. You introduce a protein called an antigen to the immune system. It can be by injection. It can be in the skin, through the oral tissues. All these have various advantages and disadvantages depending on the disease and whatnot. But the idea is to get the immune system, give it some experience so it can mount an immune response. I'm not going to get too much into immunology here, but there's two hands of the immune system. There's the B cells, the T cells. One makes these antibodies we've talked about. The other makes memory and little lock and key so the actual cells can go attack an invader or an infected cell. And the combination of the two, fantastically complex. I don't pretend to know it very well. But this combination effectively can protect us from a lot of infections. Now, when COVID came out, we were all scared. People were dying all around the world. Hospitals were full. They were getting refrigerator trucks for the bodies. We were all really scared. The intensive care units were full. The healthcare providers were scared. It was a tough time. And many of us shut down, locked up for a year or so while this was happening. And there's this technology, apparently it's been around for 10 or 20 years. This technology is around whereby you can inject something called a messenger RNA, and you can program a cell to mount an immune response to exactly what you want. It's unbelievably accurate and precise. And I believe the inventors got a Nobel Prize. If they didn't, they're going to. In fact, this technology may be used for all kinds of additional applications, maybe cancers and autoimmune conditions and whatnot. But these are instructions getting into your cells a very different way.
Yeah.
So they're not they were called vaccines, but in fact they're I don't know what I ever want to call. I didn't even think of what I was going to call it. Maybe a focused transfection device. I don't know. Maybe that's not accurate. But this has raised some current concerns, hasn't it, Nathan?
Well, I think for one thing, when you do a regular vaccine that we all kind of think about, and we've been talking about here, that will eventually provoke your cell to create some genetic material, and from that, create an antibody, and so there is genetics in a regular vaccine, and we have mRNA in our cells all the time.
Sure. I mean, it's using a pre-existing system. It's not an alien molecule.
So the mRNA and some of these vaccines that we made more recently for COVID just bypasses one of the steps, but it doesn't necessarily do something in a completely novel way. And the mRNA shots were actually first formulated when there was a SARS virus.
Yes, an avian flu respiratory virus.
Yeah, so this is a technology that has been around, it has been given, and so we know how that has affected people, and it hasn't had any long-term impact in that respect. So it's a newer kind of a technology or application of it, but it's something that's been around for probably longer than people realize.
Yeah, now there has been some concern that, particularly in young folks who are less likely to die from a COVID infection, that a rare side effect of these, I'm going to call them mRNA vaccines, just for lack of a better word, might provoke an immune response against one's own tissues, then maybe there's an increased risk of inflammation of the heart, a myocarditis in young children. Do you have any thoughts on that?
Yeah. I think there's a real risk of increased risk of myocarditis with the COVID vaccines, and that I don't think it's a huge increased risk from the general population of people who can get myocarditis from other viruses and other things.
Sure, it happens for other reasons.
Whether or not you've been vaccinated against COVID, you can get myocarditis, and so there's an increased risk in that case. But there's also a huge risk of myocarditis and other untoward effects from getting COVID.
COVID itself.
So, and I think the cardiovascular risks of COVID infection are worse than the increases for myocarditis with the vaccine.
Interesting. Yeah, it's really hard to weigh all the perturbations, all the different ways this can go, and that's why you have to look at large populations to try to figure out what is the appropriate risk and benefit. And a couple episodes ago, I was talking to an expert on public policy at a think tank, and they realized early on that maybe the best people to vaccinate are not the vulnerable people, the older or the sick people, although that's important too. Maybe it's the young people that may spread these conditions. Maybe they're the best people, the forward-facing people that actually might be the best people to vaccinate. That's kind of interesting. Another interesting twist on the COVID mRNA vaccine is that it's certainly proven to reduce sickness and hospitalization and death in those that receive it, but they still might be able to have a light case, to use maybe an inappropriate term, and still be able to spread the virus even though they're not sick. Do you have any thoughts on that interesting phenomenon? Because if you're immunized against polio, you're not pooping it out. It's not getting in the water, and you've stopped the transmission. Whereas COVID might be a very sneaky virus that might get through even though you're vaccinated.
Yeah, and I think that brings about a really important point about COVID is that it's new. And we've been studying COVID for less than 5 years,
Right.
and that that's why it's COVID-19, because it came just the end of 2019, and so the way that it's transformed and changed and the effects, and I think it's a new science, and so there's room to change our recommendations, to advise differently in terms of vaccines, or to change the formulations of the vaccines. But the long and the short is that we're doing the best we can.
Yeah, people need to understand that when you see a change in policy, it's not because these doctors are idiots or these PhDs lost a few marbles. It's because information changes, the data changes, and science should not be wedded to a preconceived dogma or a notion. It needs to be flexible, given new information and new data, doesn't it, Nathan?
That's I think the definition of science. I mean,
yeah.
So I try not to be so dogmatic in my practice that I can't change my mind about something if I'm presented with new and compelling information.
Right.
So
that actually shows more intelligence than digging your heels in and sticking with something that truly becomes outdated and not scientific.
Yeah.
Well, Nathan, this has been a fascinating discussion. Are there any other concerns or topics about vaccinations you'd like to mention?
I think it's a personal choice for families to make. How they want to do, how they want to implement healthcare for their children. There's lots and lots that we could talk about vaccines for in perpetuity, basically. But,
right.
The choice of who can vaccinate, the choice of when to vaccinate, whether it's the parent or children's choice. These are all things that are not exactly black and white.
Right.
And so I keep learning. With every day, there's some little bit of new information. Sometimes a lot more than others, but.
Yeah,
that's one of the great things about being a doctor is it gives me an excuse to keep on top of things and keep learning.
Yeah, a recurring theme here is that it never stops. Doctors do not stop learning in medical school, or they shouldn't stop learning in medical school. And part of what you get going to a physician is someone who's kept up to date, who's reading their journals, who's getting who are continuing education credits and all that stuff, and tries to roll with this tidal wave of information that we're exposed to every day.
Mm-hmm.
Fantastic. Well, Nathan, thank you so much for your time today. I've learned a lot. Hopefully our listeners have learned a lot about childhood vaccination. And I look forward to having you back sometime to talk about some other pediatric topics.
It'd be my pleasure.
Thank you, Nathan.
Thank you, Gil. Nice to see you.